Hello friends, this is a case of robotic incisional hernia repair, and initial adhesiolysis we are doing by laparoscopic seizures just to minimize the cost of the instrument. And one of the advantage of using laparoscopic seizures is that you can use it as a spatula and you have a little tactile feedback. So, with the left hand you can press the the content, and then with the right hand you can do the adhesiolysis. The problem of the robot is that there is no tactile feedback and you have to depend upon the assistant who is pushing the content of the hernia sac. But in laparoscopy you can use your left hand to press the defect, and with the right hand you can separate the adhesions. So, after doing the adhesolysis, then we will dock the robot and we will do the entire suturing of the defect by the Da Vinci. So, this is a robotic incisional hernia surgery, and in this we have used the barb suture, that is Prolene barb suture, for repairing of the defect, and after that it was a dual mesh that was used for performing the mesh repair of the hernia. So, this patient had the previous laparotomy performed, and that is why you can see a lot of adhesions are throughout the abdominal wall, but luckily most of these adhesion does not have a direct incarceration of the small bowel, and most of those adhesions are omental adhesion, and some of the adhesions has the bowel, but directly serosa is not attached and it has a tag there to cut and remove it. So, first step of any surgery is to remove the content of the hernia sac, and then only you can use suturing or you can use the mesh, because unless the content is removed it is not possible. So, we can see now most of the content is out, and then we will start now surgery by the robotic. So, here the docking will be performed and the telescope will be introduced into the palmer's point, and we can see here this is docking complete, and we have a left hand, there is a atraumatic grasper, and right hand has a needle holder, and the first step is the suturing. So, here we are using the Prolene barb suture, and that we will use for the suturing of the defect, so that the gap will be approximated and then the mesh will be introduced. So, this is suturing is started, and we are taking 1 centimeter lateral to the margin of the defect deep muscular bite, which should contain the anterior rectus muscle as well as posterior rectus. And this is a unidirectional barb suture, that is non-absorbable Prolene, and we can see there is a loop there, and through that loop you can lock it. So, in this suture you do not have to do the starter knot as well. So, we can see after taking 2 or 3 continuous suture, then you can pass the needle through the loop so that it will get locked, and we can see the loop at the tail end of this barb suture, and needle is passed through that so that it is locked. Otherwise, if you are using Vicryl, then better to use a Dundee jamming knot, and that also can lock, followed by continuous suturing. So, as we can see that this continuous suture is approximating the margins, and because this suture has a barb projection, so it is not allowing the approximated part of the rectus to get separated, because it is unidirectional. So, it can allow the suture to go ahead, but it will not allow the suture to go back, and then easily you can approximate the defect and you can close the defect. Robotic has a advantage that it has a wrist articulation, and you have a motion scaling as well as rotational scaling. So, rotational scaling has a advantage that your rotation can be augmented, and if you are rotating your master controller to 90 degree, it can rotate it to 180 degree. So, these are the advantages of the suturing of the robot. One of the biggest advantage is wrist articulation, then motion scaling. Third advantage is tremor filter and the 3D vision. So, these advantages make the suturing by the robot very easy, and we can see that continuous suturing of the this defect is going on. Extracorporeal knot is also a good option in these type of defect to close, that you can use extracorporeal interrupted square knot. But as you know that robot cannot ligate the extracorporeal knot, because only we need human hand to slide the knot pusher. With the Clark knot pusher, interrupted suture can be used. So, in the robotic only option you have the intracorporeal, but thanks to this type of new suture that it will allow you, if you will use simple vicryl and then you will try continuous suture, the margin will not be approximated, because once you take one bite and then you go for another bite, first will become loose, and then again you will tight it, again it will slide back and you might have to terminate it. So, now this suture is over. After that we will take another suture. Now, this suture will be tapped there, so that it should not displace and it will not go to the bowel, and and later we will remove it out. And then there is another suture we are looking for, because very long suture you cannot handle in the robotics. So, you have to use maximum 20 to 30 centimeter suture, and this needle is pricked to the anterior abdominal wall, and this is the another suture which will start the new bite. But one thing you can do, that tail of this suture you can pass in the tail of the another suture, and then you can tie a knot, so that it will continue act as a continuous suture and your first knot will not become loose. So, here it is sutured with the first loop, and then one square knot is applied there. Now again further suturing is continued, and just to make it more secure, this needle is passed once more through the loop of the second suture. So, this also get locked. So, this second suture is also locked in the loop, and then further continuous suturing will be carried out. When you are taking the bite with the needle, your assistant should give you some feedback about the margin of the defect by pressing by the finger. So, you have to be careful that at least 1 centimeter lateral to the margin of the defect you should take a deep bite, that include the rectus as well as muscle, because by mistake you should not take a bite where really the defect is, otherwise your needle will come out of the hernia defect and there will be no advantage taking on the bite over the defect. So, it should must include the healthy tissue by the side of the defect, and that will be by the tactile feedback which your assistant can put the finger, and wherever there is a defect, obviously there will be bulge of the pneumoperitoneum. So, that also will be very easy to find out. So, this is the continuous suturing carried out throughout the defect we will close, and here we are planning to close the defect in 2 layers. So, first layer will be the continuous with the same suture, you can return back, and you can second layer can be also approximated, means just to reinforce the defect. This is the second row of the suture will be carried out. Now, this returning row, that is the second row of the suture, is started, so that there will be better reinforcement of the margin, and this bite when during returning should be taken in between the bite of the first one. So, there is a crisscross pattern of the suture line will form. So, this is the returning suture line. In this entire robotic surgery, we have used only 2 instruments. One is atraumatic grasper and one is micro needle holder. There was no seizures used because seizures part of the adhesiolysis was performed by the laparoscopic seizures, and the cutting of the suture also assistant has used the laparoscopic seizures to work. So, this is the second row of the suturing, and we will return back from where it was started. So, now we can see it is a very strong suturing now because of 2 row, and there will be no chance that the margin of the rectus will go away from each other. And after that mesh introduction will be easy, and mesh will, if any hernia, ventral hernia, if it is bigger than 4 centimeter, and if you are doing without suturing, chances of recurrence is approximately 40%. So, we should always try to first approximate the defect and then we to use mesh. However, if the size of the hernia is less than 4 centimeter, like a small umbilical hernia or very small para-umbilical hernia, so here scissors is used to cut the suture again, that is laparoscopic scissors, and then we will take the suture out. So, very small umbilical or para-umbilical you can do without suturing, and sometime very small hernia, umbilical hernia, you can use primary suture without mesh also. So, now this both the needle is taken out, and after that this is the mesh, and now this mesh will be approximated, and rough area of the mesh will be towards the anterior abdominal wall, and the plain area, that is the absorbable area, will be towards the omentum, and the mesh is supported. Here we are not using any type of this transfascial fixation, and directly tacker was used to approximate the mesh without any transfascial fixation. So, this is the tacker which is going to fire, and slowly tacker outer crowning as well as inner crowning will be performed, and we should take care that center of the mesh must be in the center of the defect, and the size of the mesh must be average 8 plus defect. So, here we can see that center of the mesh is positioned to the center of the defect, and then outer crowning will started. Here we are using absorbable tacker, so that patient will not have any nerve pain, and absorbable tackers are little expensive, but it is better. And here also you can see this part you have to do yourself, or you have to do by your any good assistant, because unfortunately robot cannot fire the simple tacker. So, this is the laparoscopic tacker absorbable, which you have to fire after again leaving the surgeon console, coming back near the patient, or if you have a good second surgeon, your assistant, he can fire. Care should be taken that tacker should not fire in between the suture line, otherwise it will come out of the skin. So, this is the outer margin going on, and all around outer margin also you should try to avoid going on the extreme margin. You should remain little away from the corner of the suture, and after that we will do inner crowning, and that way during this suturing the pressure was also reduced little bit, so that you should not have any tear on the muscle, and during fixation of the tacker also excessive pressure of the pneumoperitoneum should be avoided. You should keep only the pressure which is allow you to visualize the mesh all around, because if it is excessive pressure after removal of the gas, your mesh will be little loose. So, it is better to use the less pressure, and this is the outer crowning going on all around the margin of the mesh, and after that you can do inner crowning. So, with that fixation the surgery will be over. So, this was a simple case of incisional hernia where adhesiolysis was performed by laparoscopic scissors and the suturing was performed by the robotic grasper and needle holder. So, thank you very much for watching this video. Have a nice day.